Good morning, everyone. Welcome to yet another session with our virtual health education. Today, we're here with Dr. Olivia Kingsford, who is a headache neurologist at Barrow's Neurological Institute in Phoenix. Thank you so much for taking the time to be here with us and accommodating us in this session to provide to our patients. How are you today?
I'm doing well. How are you?
Good, thank you. Dr. Kingsford, please tell us a little bit about yourself and your educational background and what you're working on currently. I know that you're a headache neurologist, but a little bit more about that. And thank you.
Yeah, so I'm originally from California. I did undergrad at UC Berkeley, and I went to med school up in the Bay Area, kind of near Napa. And then came out to Barrow for my neurology residency and then stayed for headache fellowship. So I'm finishing up headache fellowship this year, and then I'm staying on as faculty this upcoming fall. So looking forward to joining the team.
Wonderful, wonderful. Congratulations. Dr. Kingsford, can you tell us a little bit about the difference of headache and migraine per se? What differentiates them?
Yeah, so headache just in general is a super common symptom that in some cases can be due to a primary headache disorder such as migraine, but sometimes are due to other things. So migraine itself is a genetic disorder. So basically people have a predisposition where their nerves are dysfunctional and they cause pain. And so if you have the right kind of combination of triggers, it triggers those headaches, but other symptoms come with migraine as well.
Wonderful. And what are you mentioned something about genetics as far as migraine. Are there any other factors besides genetics that go into play for people to have migraine headaches versus just a regular good old headache?
Yeah, so migraine itself is a neurological disorder. And so just people with that predisposition have all the symptoms of migraine, but anyone can have a headache. And that's not to say that patients with migraine will only have migraine type headaches. They can also have, the tension type headache that you commonly think of, like a squeezing pain or caffeine withdrawal, or different triggers can cause those symptoms. And then it's just so common that lots of people have those migraine type headaches as well.
Gotcha. So is there a thing that maybe someone that doesn't have, let's say, the genetic background or doesn't have family history of migraine kind of gets transitioned into that group of having migraine, someone that normally just gets headaches? How do you, I guess maybe the better question is, how do you categorize a headache versus a migraine? As far as
there's specific diagnostic criteria that we use through the International Classification of Headache Disorders. So we're on the third version at this point. So migraine is defined as a unilateral throbbing headache with associated either nausea or light and sound sensitivity. So you have to have those additional features for it to be considered a migraine type headache, whereas by far the most common primary headache type is tension type, which is that band-like squeezing pain that I think most people commonly think of when you mention a headache, but that's not necessarily the one that I see in my practice. Migraine is the one that's more debilitating that people actually seek medical care for.
Gotcha. And seeking medical care, I've seen a lot of, actually, when I used to work at the hospital, I used to see a lot of emergency room admissions, even for severe migraine headaches, where they said that they can't see, they just can't handle anything. So I remember seeing those types of patients. And one of the reasons for this educational video is to help patients know do they need to go to the emergency room? What do they need to do to prevent having to go to the emergency room? So with that being said, I want to transition to kind of like treatments or preventative care for headache versus migraine. So if you go a little bit into detail about that, separately or all together, that's fine.
Yeah, so my goal for patients is really to have the knowledge and have the tools to be able to treat their migraine symptoms effectively at home, so that the emergency room isn't their first line of treatment, which for many patients it often is, because a lot of people just don't know that their primary care doctor, neurologist, and headache specialist like me are out there, and there are things that you can do to help control your symptoms. The kind of foundation of migraine management is lifestyle modification, so identifying factors that kind of trigger symptoms, and then we use medications on top of it. So in medications, there's two parts. So one part is prevention, so medications you take every day or once a month or however the medicine is dosed to help prevent the headaches in the first place. And then rescue medicine, so medicine you take right when the headache starts to try to break it, so it's hopefully not getting to a point that it's so bad, so debilitating that you're missing work, missing out on family events, having to go to the emergency room. So really having tools to manage symptoms so it's not impacting your and disrupting life.
Can you name some of those lifestyle modifications, maybe?
Yeah, so the mnemonic that I teach my patients are the seeds for success. So the first S in seeds is sleep. So identifying, do you have undiagnosed sleep apnea? Do you have other sleep disorders like insomnia or restless leg or other things that impact your sleep quality that can trigger headache and migraine symptoms? So I'll often send people to a sleep specialist if that's an issue. The first E in seeds is exercise. So the American Heart Association and World Health Organization recommendations are at 150 minutes of exercise per week. So I say, recommendations for your heart health are good for your brain health. So just getting more active can actually help reduce migraine symptoms, which I know when you're really debilitated from headache, it's very hard to, want to go out and work out, but just building up little by little, just 1 minute more per day can actually help control migraine symptoms. And just staying active is good for health in general. The second E is eating. So looking at diet, but also looking at hydration. There's no specific diet that we recommend for migraine. Typically, we just recommend a Mediterranean diet. So, lean protein, lots of fruits and vegetables, healthy fats in moderation. Can help with migraine symptoms. We do know that MSG, some of the fake sugars like aspartame, can be a trigger for people. And we know that part of the kind of warning phase or prodromal phase of migraine, sometimes people get food cravings that we can associate with development of migraine. So it's not necessarily that chocolate or salty foods directly cause migraine, but the cravings are part of those migraine symptoms that you have. Hydration is also super important, especially here in Arizona. And now that the summer's coming up, it's important to stay very well hydrated. Including electrolyte supplements can be very helpful, and just being cautious about added sugars in those supplements is important too. But that helps keep the water in your blood vessels and helps you stay better hydrated, and that can help reduce headache symptoms as well. D in seeds is keeping a headache diary. So keeping track of how often you're getting headaches, how bad are they? Are you taking your rescue medication? Are they working? What triggers have you noticed? So foods, weather, stress, all big ones. And then if you bring that into, your primary care doctor or whoever's managing your headache, can be really helpful as we adjust treatment. So it can help us shape, are we going to keep you on the same medications or doing the same things? Or do we maybe want to, adjust it because things aren't working? So it's really a team effort. So I can make recommendations, but people really need to kind of take control and ownership of their symptoms to really, work together so we can, get symptoms controlled. And then the last S in seeds is stress management. So stress is a huge issue.
I was just going to ask you, I was waiting for you to finish to be like, is stress a contributor?
Yeah, huge issue for people. So mindfulness, there's actually evidence for yoga and helping with migraine, biofeedback. So in our practice, we actually have a chronic pain psychologist who's been such a helpful resource for people in terms of, one, kind of helping learn coping skills to deal with having pain all the time. So these are for usually the more refractory, uncontrolled patients that are really debilitated, but can be helpful for really anybody, and just being mindful of stress as a trigger, and finding ways to kind of mitigate that stress can help control headache symptoms. One technique that I really like is called diaphragmatic breathing, and it's nice. You have to breathe, and so you can do it anywhere, and you don't necessarily have to step away. So if you're in a stressful situation, it's a really manageable and useful tool that you can implement at any point in time.
Okay, wonderful. And now that you brought up stress, triggered a question in my head is, so since you deal with a lot of patients that have headache and migraine, and that's your specialty, as part of your treatment plan, do you ever address like maybe depression and anxiety in order to kind of keep the migraine at bay?
Yeah, so it's not something that I directly treat, since I'm not, trained in that field, but identifying it and then connecting patients with resources is extremely helpful. And, making sure that we're checking in and making sure those symptoms are controlled if people are under treatment for it can be really helpful in managing migraine symptoms.
Wonderful, wonderful. And thank you so much for giving all that information. I guess the last thing I wanted to ask is, you mentioned about daily treatment and then treatment kind of at the onset of migraine attacks. If you could differentiate between the two, who needs to be on a medication on a daily basis, who needs to be on both, and who needs to be only on, as needed medication.
Sure. So anyone with migraine needs a rescue medicine. So you need a tool to break your symptoms as soon as possible. And there's some evidence that the sooner we treat it, the less intense symptoms are. And over time, you actually can get better control if we're treating what we call the headache phase is called a migraine attack. So treating the migraine attack as soon as possible can actually reduce the burden of symptoms over time. The criteria for a preventative medication is 4 or more headache days per month. So it seems really low. I think tons of people are very surprised that I think many more people could be on preventative treatments than are. And I know a lot of people don't like to be on medications, and it's not necessarily that you need to be on it forever. The course of migraine is at times symptoms are worse and at times symptoms are better. So when symptoms are worse, we're more aggressive with treatments and getting you on a preventative. But then once things are controlled, trying to back off and get you off so that you're not stuck on, medications forever. However, they are safe, and if you need it, then you need it. And the goal is to really control symptoms and let people be able to live their lives the way they want to. So going to work, going to family functions, going out to social events, not being limited by their headache symptoms. In terms of preventatives, in the past, we didn't have migraine-specific medications. So we kind of borrowed from other fields where people were on these medications, and we found that they were effective in reducing the number of headaches they had. So these tended to be antidepressants, anti-seizure medicines, and blood pressure medications. And so now in my practice, what we actually do is we'll use these even if you don't have those symptoms or those conditions. So putting you on one doesn't say, okay, you have hypertension or you have depression, but we're using that added benefit from those medications to treat headache symptoms. If you do have those conditions, then we can kind of tailor it based on each person's, health conditions and really what's the best fit for them. Now we do have migraine specific medications, and some of these are once a month injections that you give yourself at home. Some of them are pills that you take every day or every other day. There's one that's an IV infusion, so you actually come into our infusion center and get it every 3 months. And then actually Botox is approved for migraine, and so that's a specific protocol. It's 31 injections given every 12 weeks that can help reduce the number of headache days per month. And that's a great option for people that, meet the criteria for it.
Gotcha. I know you say Botox, and as soon as you say Botox, people are going to be like, well, if it's for my headache, is it covered by my insurance? So is it typically, if it's really honestly for migraine, it's covered by insurance?
Yeah, so Botox specifically is for chronic migraine. So chronic migraine is defined as 15 or more headache days per month, and at least 8 of those have to have those associated migraine symptoms. So the nausea or the light and sound sensitivity. Often what insurance wants, and it kind of depends on each plan, is usually you have to try 2 of the older classes of medications before they'll approve Botox, but in those cases they will. And so it may not be something that, you know, your doctor offers right away as the first line treatment, but maybe once you've tried things and we know insurance is more likely to cover it, that's when I typically bring it up as a treatment option. And yeah, so people get it covered and they come in and, you know, you're not paying however much per unit like you have to do cosmetically.
Yeah, very cool, very cool. And I know I said my previous question was going to be my last, but I have one more question for you.
Sure.
What about over-the-counter pain medications? Are those at all effective? Let's say you're stuck somewhere, you don't have your medications. Are those at all effective? NSAIDs, which are non-steroidals, ibuprofen, Tylenol, are those effective?
They are. So NSAIDs are actually the first line treatment for rescue. But we want to be cautious because if we're using them too much, you get a phenomenon called medication overuse where the headaches actually get worse. And so it's kind of counterintuitive, but your body gets used to having it in your system. When it's not in your system, the threshold to have those headache symptoms is much lower. And so you tend to have more headaches. Ibuprofen, naproxen are great options. Tylenol is also a great option. But there are also migraine-specific rescue medications. So the triptans, like sumatriptan or rizatriptan, are often where we start. And now we have the gepants. So Nurtec, Ubrelvy, zavegepant are the newer ones that we have. And all of these are the ones you take right when your headache starts to try to break it before symptoms get too bad.
And they're generally effective, these rescue medications.
Mm-hmm. Yeah, they're all very effective. The triptans are contraindicated or not approved for people with a history of stroke or heart attacks because they theoretically can narrow blood vessels and so increase. So people that have, you know, that history of decreased blood flow to the heart or the brain, that's a heart attack or stroke, we avoid it in those cases. That's not to say that they actually cause heart attacks and stroke. We just want to minimize that risk.
Okay. So for those types of patients, you give the other rescue agents like the newer agents that are now available.
Yeah, and we can often, given that history, get insurance to cover those medications.
Wonderful. Wonderful. Well, this was very informative. I know you're very busy. You always are so responsive when I was emailing you back and forth. So I really appreciate your time and all the information you provided for us and our patients. Our patients have the option to send in questions if they have any specific questions. So if any questions come in, I'm going to relay them to you so you can answer them at your earliest convenience. No rush at all. And again, thank you so much for being here.
No, of course. Thank you.